see them from the day they were born until the day they are coming to us at the age of 15. We probably did see them, but we didn't pay attention to it. And it's very much the same for malnutrition. We see those kids. We see those kids in the clinics. We see those kids in the hospital. But we do not pay attention to their nutrition until they get to the lowest point. And this is a chance that we should not miss when we treat children. Now, growth failure is a progression. It starts with reduced weight gain velocity. They stop growing enough. Then they stop growing at all. Then they start losing weight. Afterwards, linear growth, height, goes slower. Then it stops. And only then the brain is affected, because the body is very smart and it protects our brain. But we can see those children throughout those stages. And whenever we stop it, exactly as the professor mentioned before, we can stop this vicious cycle of malnutrition. And we have the opportunity to do it. Now, the definitions of malnutrition were previously discussed. We basically use the definition of -2 standard deviation or below the 3rd percentile for age. This is something that was recently published by the American Society, the ASPEN, and they added to the definition 2 important things. They differentiated between children who have malnutrition that is non-illness related, is not related to illness. They do not eat. Why do they not eat? Either they're picky eaters, or they don't have food. Unavailable food, they don't eat. So it's not related to illness, or it could be illness related, which we will talk about. And then they divided it into 2 time categories. One is acute malnutrition. Acute malnutrition means less than 3 months. When it's chronic malnutrition, it's above 3 months, and this would probably affect their height also. What is the prevalence? And I think that the prevalence was very nicely described before. When I prepared for this presentation, I went to look at the data from Vietnam. And I have to say, Mr. President of the Academy of Pediatrics in Vietnam, I was very impressed. I saw the numbers, and I saw that in 20 years, you were able to reduce the number of stunted children from 60-something% to 25%, which is very, very impressive. Still high, but very impressive. And at the same time, I may say you have a reasonable low number of obese children. Okay? So these are the numbers today, and it's still quite high. And as mentioned before, throughout the world, there are 160, some say almost 200 million children that are stunted. What about hospitals? It was shown before. It changes between countries, it changes between hospitals. What's most striking about the data from hospitals is the fact that it did not change in the last 30 years, okay? It did not change. It ranges from 10 to 50% throughout the world, but there has not been a change. When I looked at data from Vietnam, I saw the studies that you've mentioned about 25 and 27%, but I also saw these studies. What it does tell us also about Vietnam, that it didn't change a lot. So if we think about the prevalence and we think, what can we take from it? The prevalence is high, okay? It's high, I may say even very high. 10 to 40% of children that come to a hospital will be undernourished or malnourished. It doesn't really matter, as said before, if you come from an affluent country or you come from a poor country. It doesn't matter if it's a medical reason for hospitalization or surgical reason for hospitalization. What it really tells us that if it didn't change for 35 years, it's because we physicians, we do not recognize it, or we don't think that it's important. And I think that this is one message that we should take from here, you should take from here. This is an important issue that should be addressed by us. Okay, now we go to the effect of malnutrition on hospitalization and the effect of hospitalization on nutrition. When a child is hospitalized, even for a mild disease, 20 to 50% of children will have a deterioration in their nutritional status during this hospitalization. And it is related to the disease, and this was previously mentioned. It can be related to the disease, to inflammation, to fever, to infection, to other problems, to anorexia that is associated with the hospitalization. But it also belongs to us, to hospital-related issues. What are the hospital-related issues? First, do we know that the food that we give our children is the food that they like to eat? I can assure you, in my hospital, we do a survey within the patients. The lowest score that we get is about food. The kids do not like our food. If they don't like our food, they don't eat it. Now think about a child who is coming to you and has a suspicious of inflammatory bowel disease. So in the morning he goes to do a CT, he has to be fasted, and then at 2 o'clock he has a colonoscopy, okay? So he didn't eat from 8 o'clock in the morning until 2 o'clock in the afternoon, and then he comes back to my ward, to my department. Do we make sure that he has the food that he needs to eat? Do we make sure that the food that was given to the children at 12 o'clock is still something that he can eat? We don't. I don't know about you, but we don't. But this is something that is crucial. We don't think about it. And if we think about it, we can really save those children. Now, it was previously mentioned that the severity of malnutrition is related to increased hospital stay, is related to more infection, to weight loss during hospitalization, and to decreased quality of life. Now, I would like to show you some studies about the outcomes in patients that come to hospital. First, we start with surgical patients. This is a study from France who looked at approximately 1,000 children. 11% of them were malnourished. Children who were malnourished had increase of post-operative complication. And if we are surgeons, we say, why does it happen? But they do have more post-operative complications, they do have more infections, and they have increase in the length of stay. This is a very nice study that was done on children that did the surgery, like thoracic surgery or abdominal surgery, 175 children. And if you compare children who were malnourished versus children who were not malnourished, you see that they have infectious complications, minor complications, and the length of stay. Take a look at the length of stay. It's 8.2 days to those who are malnourished, compared to 5 days to those who have good nutritional status. So it's a 3-day difference. It's a huge difference. Now, this is a very striking graph. This is the survival curve of pediatric oncology. If you look at the survival curve in blue of children who are malnourished compared to children who have normal nourishment, or at least reasonable nourishment, you see a huge difference in the survival of those children. Look at the numbers. Malnourishment is associated with higher increase of death in your hospitals, okay? And length of stay, and neutropenia, and bacteremia, okay? This is something that you have to remember. This is a nice study from 16 countries who looked at critically ill patients in intensive care units. Look at the numbers, what they have found. 53% higher mortality at 60 days. Infections are more common. More days on ventilation. Increase in hospital stay. The numbers, if you see here, 53% increase here in mortality. 88% increase in infections. And this is only due to nutrition. But what about those children who come to us and don't have a serious disease? Does it affect them? Because these are most of the children that we see in the hospital. It certainly does. If you look here at this graph, you see that even normal children, 20 to 25% of them will have a significant reduction in their nutritional status that may affect their hospitalization and their long-term consequences. And the more they are in the hospital, the more that they lose weight. This is 8 days, 6 to 8 days, and 3 to 5 days, and this is the percentage of children who are losing a significant BMI. So you see that if you're hospitalized for more than 8 days, many children will lose a significant BMI. And this brings us back to this, but here it shows you the results of this malnutrition. Loss of lean body mass, muscle weakness, developmental delay, infections, immune dysfunctions that were previously mentioned, delayed wound healing, and hospital stay. Now, you have to think about the costs of malnutrition. This is a very, very nice study from the United States that looked at 10 years of hospitalization and compared children who were malnourished to those who were not malnourished. Look at the difference on the days. 3.8 days versus 9.7 days if you are malnourished. Look at the amount of money that is spent on one hospitalization. $55,000 instead of $17,000 if you are well nourished. This is a very nice study from the Netherlands, from Holland, that looked at the cost of hospitalization in the whole of the Netherlands. It was recently published, and it showed that if you treat those children, you can save 80 million euros a year. Now, I have to tell you that the Netherlands have decided a very, very important decision. They are the first country in the world in which it is mandatory to report to the Ministry of Health the nutritional status of every child that comes to the hospital. And with this, they will save not only money, but also a lot of health consequences to those children. And if you ask me, within several years, every country in the world will have to do a nutritional evaluation when children are admitted to hospitals. So what are the long-term effects of malnutrition? I guess that you've all known and heard that it will lead to lower weight and height, poor developmental scores, poor work habits, etc., etc. Look at the long-term effects on height. This is very interesting. Children who were malnourished will be 6 centimeters shorter than children who are well nourished. And it didn't really matter when you did all the control for maternal size and economic status, etc., etc. Only malnutrition would lead to 6 centimeters reduction in height. What about weight? If you treat them early on the green curve, if you treat them early, they regain weight early. If you are delayed in treating them, it's going to take them a longer time to come back to their weight. What about their brains? This is a study, a big study that looked at the effect of undernourished on scores, on IQ scores, and it showed that children who had weight for age and height for age who were lower had 3.5 times more likely to suffer from low IQ. Okay, low IQ, significantly low IQ. This is another study from Tanzania who looked at 1,000 children, and here you see on the upper panel is cognitive function, communication function, and motor development, and here on the red line is the normal, it's 0. It's the average. Everything that is below the average, every child that is below the average has an impact on cognitive, communication, and motor development. But if you treat them, if you give them stimulation plus feeding, you see here on the red, this disappears. The change in the IQ level and the change in all the cognitive function is regained only with giving them proper nutrition and stimulation. Now, if you think that malnutrition only belongs to you when you're a child, this is a study that showed that if you were a child and you were malnourished, it's going to affect your income when you become an adult. Okay, this study, you can see controls here, and people with history on the black, people with history of malnutrition. So if you have history of malnutrition, when you grow up, you will earn less money. And your income and your work effect would be lower. So malnutrition does not only affect the person, the child, it affects the society and the community. It results in a huge loss of the gross domestic product in a country, 6% of the gross domestic product in poor countries. Okay, if you just decrease malnutrition by 1%, and as the professor said, you will do it until 2020 and 2030, every percent that you take down has a huge impact on poverty. Every percent that goes down is 4% change in poverty. Okay? And the risk of death, if you have moderate malnutrition is doubled, and if you have severe malnutrition is 7 times higher. 7 times higher if you compare it to normal weight children. Now, we physicians and nurses, we used to say, oh, but I can look at this child and I can tell you if he's malnourished or not. And the question is, can we really do it? And in this study, they took 44 children and they took very experienced physicians. And they say, we would like you to look at those children and tell us if you think that they are malnourished. And the results were very surprising. If you look at the number of physicians who had the right answer, okay, it is very low. It is very low, and we cannot just look at a child and know that he is malnourished, and it's significantly lower if he is below the first year of life. So it tells us that we really need tools, objective tools, and we cannot trust our eyes. So what are the components of nutritional assessment? I don't have to tell you that you have to do medical history, dietary history, anthropometric measures, body composition, physical exam, and lab. But we cannot do it to every child that comes to us. And this is why people throughout the world are trying to develop a scale that would be a good scale for the evaluation of malnutrition. Now, Strong Kids was previously mentioned and shown. This is why I will not talk about it, but it's a very good tool. And the other good tool is the STEM tool that some hospitals that we are working with are using, a STEM tool which has a good specificity of about 72-75% and sensitivity of approximately 90%. It's a very simple tool, and if we will have time later to discuss it, I will be happy to give you, but it's a 3-stage tool that will tell you if the child is at risk and if you should go through the evaluation that I mentioned before. Now, medical history, I guess that you all know this, what you have to ask in the medical history, things that are associated with nutrition and things that are not associated with nutrition. When you look at the assessment of food intake, which is also a topic for another lecture, it's not an easy thing to do, but when you are in the hospital, you have the chance of doing what's written down there, which is really doing an accurate 24-hour recall of what those children eat. Anthropometric measures was mentioned before, weight, height, head circumference, and BMI. and you have to compare them to standard growth curves. We have tools to evaluate body composition. I guess that you know most of them. Underwater weighing, it's the old gold standard for the evaluation of fat mass. I don't know many people who like to go and weigh themselves this way. I don't know, but it really works on the same system, but it uses air that goes in and out this chamber. We can use DEXA, we can use bioelectrical impedance, mid-arm circumference, skin folds, and in some studies we use MRI for the evaluation, which is actually the best way to evaluate the amount of fat. And you can see here, this is fat. This is a case of an obese child, but it is very, very accurate. If the child is very malnourished, we will see signs in the physical exam, such as change in body temperature, heart rate, which may be high if you have a B1 deficiency, or low if you are malnourished. And if any of you, I think that most of you would know, there are sites in the body that will show signs of malnutrition. These are important things we should remember, because sometimes when we see something, it gives us a clue that we have to look for a specific nutrient. A child could have good nutrition with a specific nutrient deficiency. Biochemistry, I have to tell you that biochemistry, mostly in the hospital when a child is hospitalized, is not a very good tool. We physicians, we like to take blood and we like to draw, to take some examples, but usually it does not, unless we suspect a specific deficiency, it is not a very good tool because it is affected by the acute disease. Albumin, prealbumin, they're all affected by the acute disease. How about evaluating energy expenditure? This is something that we do in intensive care units. We would like to give those children the amount of energy that they need, and we can do it using equations that you probably know, or we can do it, these are the equations, you can find them in the textbooks. These are the Schoenfeld equations, or what we usually do is we evaluate the indirect calorimetry of those children to evaluate the exact amount of calories that they need. And this gives us better results in our ICU. So, to summarize, it is growth, chart history, medical history, food diary, and lab. This will give us the complete nutritional picture. Okay, so what do we do to those children? Now that we know that they are malnourished, what can we do? So, it is a stepwise approach. Most of the children will suffice with nutritional counseling. Okay? Although it is not a very good tool, counseling, but sometimes it will be enough for those children, especially those who are acutely ill and don't have malnourishment when they come to the hospital. Then we go up to oral supplementation, oral nutritional supplementation, or ONS, enteral feeding if needed, and if a child cannot tolerate enteral feeding or has problem with the gut, we will go to parenteral nutrition. Now, this is an important slide because we all know that if a child is very sick and he is in the intensive care unit, he needs more energy, he needs more protein. But it's not only this. Even if a child comes to you with bronchiolitis, okay, even if a child comes to you with pneumonia, and of course if he comes to you with diarrhea, he has different requirements.